is that it's an opportunity to fake brilliance, but to actually be brilliant. So, a lot of topics here, a lot of things I would like to cover. Uh, yeah, I think acute kidney injury is a lot for me right now. So let's go to smaller this one. Chronic renal failure, reversible causes. We have dehydration, hypotensive shock. We have analgesics, drugs, analgesics, infections. We can have infections, drugs, infections, dehydration, NSAIDs. What else is there? Obstruction. Yeah, obstruction such as a stone can be relieved. Uh, so that is for chronic hematuria causes and so hematuria. Yeah, causes of hematuria can be hematuria should be centrifuge. Centrifuge hematuria can have sediment. It can have supernatant. If it is supernatant, we do dipstick heme to check whether it is actually there or not there. If it is sediment is there, it's direct gross RBC, it's hematuria. If it's not there, supernatant is there, we do dipstick. If dipstick is positive, means it is actually heme. It can be myoglobinuria, hemoglobinuria, and we check for the plasma color. If it's negative, it's hemoglobin or myeglobin. So myoglobinuria, hemoglobinuria, hematuria. The negative in case of porphyria, bituria, and yeah, pinozapidine. So this is what you should think of when you think of hematuria. An examination of urine appearance. Red hematuria. When it is red color, that is all. Causes of approach to red urine. Approach to red urine, we don't know. Red urine, either it is sediment supernatant, uh, dipstick, uh, hemoglobin or beetroot, porphyria, pheno. Drugs and pigment. Okay. Hematuria may be visible across the microscopic, macroscopic site of bleeding. Causes of painless hematuria. We have neoplasm, we have prostatitis, we have trauma, we have glomerulonephritis, we have uh, pyelonephritis, papillary necrosis, uh, acute tubular necrosis, renal cell carcinoma, uh, vasculitis. Okay, so all these causes of RBC cast you can write as hematuria. So we have four causes: malignant hypertension, we have glomerulonephritis, we have vasculitis, thrombotic angiopathy, microangiopathy, and two more causes you can list out, which is tumors and trauma. Tumors, trauma, schistosoma. This much should come for hematuria. So remember, RBC casts are four causes of hematuria. We can have, or you can use this nice diagram for hematuria, page 884, this diagram, 13.4 figure, okay? We can have at this one, we can have vasculitis, we can have glomerulonephritis, we can have malignant hypertension, we can have neoplasm, we can have trauma, we can have schistosoma, we can have thrombotic microangiopathy. Again, because of stones also it can be there. Is that fine? How do you clinically localize it? Site of bleed 13 point. Urethra. Blood is seen at the start of voiding is urethra. Bladder, blood diffusely present throughout urine, glomerular, cola color, red dysmorphic, renal pelvis lower, red color, prostate, blood only at the end of maturation, uh, lower urinary tract, uh, blood at the start is urethra, blood at the end is prostate or carcinoma, then throughout is bladder. Three things you remember. Just blood at the start. This is prostate or bladder, blood at the end. Glomerulus cola colored urine. And this is present throughout. This much you remember for site localization is the causes of hematuria. Okay, so this table, these four causes, remember. Vasculitis, malignant hypertension, vascular glomerulonephritis, vasculitis, malignant hypertension, and thrombotic microangiopathy. Thrombotic microangiopathy. Apart from this, tumor, trauma, neoplasm, and stones. Okay. Then localization, beginning, end, throughout. Done. Simple, 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 simple. Acute four causes of this one and indications for dialysis. Indications for dialysis is like the God-given question. It will definitely, definitely, definitely come for the exam. Okay. So let's just see through that quickly. Okay, so in dialysis, we are going to talk about indications for urgent renal replacement. Just remember these five. Fucking remember these five. You have to remember these five. Pulmonary edema refractory to treatment. Hyperkalemia refractory to treatment. What is hyperkalemia? Greater than 6.5 milliequivalents or greater than 5.5 milliequivalents with rhabdomyolysis or signs and symptoms of cardiac and muscle breakdown. Uremia pericarditis or uremic encephalopathy or seizures. Severe metabolic acidosis, that is pH will be less than 7.1, and acute poisoning. Five indications you should know for till death. Okay. Acute pulmonary edema refractory to treatment, hyperkalemia refractory to treatment, that is greater than 6.5 milliequivalents, greater than 5.5 milliequivalents with rhabdomyolysis, signs and symptoms of cardiac and muscle breakdown, uremia, that is pericarditis and uremic pericarditis, uremic encephalopathy, severe metabolic acidosis, and acute poisoning. 19 hours of surgery video also pending. 17 hours of ortho, 19 plus 17, plus around 40 hours of textbook, plus at least 8 hours of this on textbook, plus around 10 hours of revision of old topics, plus practical. Come on, dude. How did you go lost? Indications for this one. Indications for dialysis over renal failure causes we have pre-renal, renal, post-renal. Should be fine. Criteria for acute kidney injury. We have three criteria. We have KidGo classification, we have AKN classification, and we have rifle classifications. Do that criteria. Okay, greater than 0.3 milligram per deciliter for 48 hours or greater than 50% in 70 days from baseline creatinine. Acute tubular necrosis, etiology, and acute tubular necrosis tomorrow. This is tomorrow, baby. Fine. Chronic renal failure also tomorrow. Hemodialysis indication. Okay, so hemodialysis indication is different from this indication. Let's see how. Basic principle, access, complications. There are types and indications for dialysis. Hemodialysis is the most common form of AAT. I used in this. I just tried the same indications for peritoneal this one also. Okay. Same pulmonary edema, refractory to treatment, hyperkalemia greater than 6.5, greater than 5.5, and then we have uremic pericarditis, uremic encephalopathy. We have acute poisoning. We have metabolic acidosis, that is pH less than 7.1, and signs and symptoms of cardiac and muscle breakdown. Dialysis and acute kidney injury, three causes. Again, acute pulmonary edema refractory to medication, hyperkalemia, same thing. Complications during dialysis. If I have mentioned in peritoneal, complication during dialysis, most important one, hypotension. Apart from that, because of electrolyte imbalance, we can have cardiac arrhythmias. We can have pulmonary edema, air embolism, hemorrhage, infection, and hard water syndrome. There's also two special: dialysis dementia and dialysis disequilibrium syndrome. Okay. Hypertension is a major complication during this one because of excess removal, the rapid reduction in urea in the extracellular compartment and inadequate filling of the compartment, abnormal venous stone, autonomic neuropathy. So it can be because of autonomic neuropathy, it can be because of excessive water removal. Okay, then we can have cardiac arrhythmias, we can have hemorrhage due to the anticoagulant. Due to we put what anticoagulant warfarin, not this one, not fractional, nothing. Okay, so we can have hypertension as a main complication. Other than that, we can have hemorrhage due to the medication. We can have cardiac arrhythmia due to hypokalemia. We can have air embolism. We can have pulmonary edema. We can have hard water syndrome, failure to soften water resulting in high calcium. This is like high calcium in this one in the water. Then we have dialysis dicyclone syndrome because of electrolyte abnormality. This one we have cerebral edema and cerebral symptoms. Then dialysis dementia may develop in long-term hemolysis patients because mainly because of aluminum toxicity. Dialysis patients during dialysis session, cerebral edema, cardiac arrhythmia, hemorrhage due to anticoagulants, air embolism, hard water syndrome, pulmonary edema, infection, hypertension mainly. Okay. So complications of dialysis done. Then peritoneal dialysis, three indications of peritoneal dialysis. So preferred mode of dialysis for young children, severe hemodynamic instability and patients with difficulty in vascular access. Peritoneal dialysis indications. In infants and young children, in severe hemodynamic instability and difficult vascular access. Okay. Uh, Peritoneal dialysis indications done, and this is something you're forgetting. So, young children and infants. Then, in severe hemodynamic instability and difficulty in vascular access. Contraindications to renal transplant are in case of like fucking issues. Okay, like vasculitis, systemic conditions. When we have reversible conditions, we have systemic reversible conditions such as uh, hypovolemic shock, analgesic use, obstruction, infection, and systemic kind like diabetes, or we can have diabetes, we can have tumors, we can have infections, diabetes, tumors, renal tumors, other tumors, infections, vasculitis. Those are the contraindications for renal transplantation. Reversible causes. Reversible renal involvement, first thing. Vasculitis, uh, non-renal causes such as infection, substance abuse probably, or these are relative in substance abuse, renal failure, mental retardation, refractory congestive cardiac failure, psychiatric illness, DIC, infection, diabetes, we have malignancy, we have less than 1 year, greater than 75 years age. Okay, so in contraindications for renal transplant, reversible this one, vasculitis, we can have apart from this IV drug abuse, psychiatric, very important is congestive cardiac failure, and then we have DIC. Relative is diabetes, infection also comes here only. Relative is diabetes, tumors, other malignancies. Okay, this much is done. Good. Urinary tract infection, 4 causes, 3 risk factors, pathogenesis, and symptoms. Something called urethral syndrome. Is to urethral irritation. This cause may include hormonal imbalance, urethral injury, ST. Symptoms include frequent pain and difficult urination, relaxation techniques. Okay, urethral syndrome is basically uh, leads to urethral irritation, cause is unknown. Urethral irritation, urethral syndrome. Unknown etiology, we have it can be because STI, injury, anything. It has frequent, painful, difficult urination. Management is analgesics, relaxation techniques. Okay. Uh, Urethral syndrome done. Uh, urinary tract infection, MI. 4 causes, risk factors, pathogenesis, symptoms. UTI. What is UTI? UTI is definition not anywhere. Okay. UTI, 4 causes of UTI. UTI can in males we can have benign prostatic we can see divide the causes like in your males we have a UTI. So the male has a UTI because of what? It can be because of any chronic condition. It can be because of an obstructive condition. It can be because of an immunosuppressive condition. It can be because of anything. So causes, if I had to write, I would definitely write diabetes or immunosuppressive conditions. Then we can have benign prostatic hyperplasia. We can have polycystic disease. We can have renal stones. We can have catheterization, use of analgesics, all this stuff. Okay, give me 1 second. Multiplication of organism in the urinary tract and stuff. Presence of more than, see, definition is important. Presence of more than 10 to the power 5 high power field. Presence of more than 10 to the power 5 colony forming units per ml of urine. Okay, that is UTI. What are the causes in male? Obstructive neurogenic bladder in male. We can have ascending infection, colonization of distal urethra introitus, that is in female. Entry from bladder, ureter, more common in female. Obstruction due to benign prostatic hyperplasia, tumor strictures calculi. Neurogenic bladder as seen in diabetes, tabes dorsalis, multiple sclerosis. Stasis, less common route of because of blood supply. Bacteria can seed the kidney, non-enteric this one. So that stuff. Okay, so this much is fine. In males, what are the causes of UTI if they ask? We have obstruction. In this we have obstruction. In this we have calculi, calculi, benign prostatic hyperplasia. Then in obstruction then we have neurogenic bladder. We have hematogenous root. This is seen in case of infective and endocarditis, disseminated infection, all that stuff. Neurogenic bladder in tabes dorsalis, SLE, spinal trauma, uh, To see also see in patients with it's enough, bro. Causes, risk factors for men. Pathogenesis we have. Pathogenesis is this one. Colonization, uroepithelial hyperpenetration, uroepithelial penetration, ascension, and then pyelonephritis followed by AKI. So in this, what we have colonization by bacteria, fimbriae, ascension, penetration, ascension, attachment, penetration, ascension. Toxin inhibits peristalsis, then biofilm formation, then parenchyma. It will inflame pyelonephritis, inflammation to be interstitial edema. So in pathogenesis, we have colonization, uroepithelial penetration, we have ascension, parenchyma involvement, pyelonephritis, and AKI. Pathogenesis, we could talk about fimbriae, talk about toxin, talk about, yeah, that's it. That's it. Okay, symptoms. Frequency, dysuria, costovertebral in case of this one, painful proctitis in case of this one, flank pain, backache, costovertebral angle tenderness, psoas muscle spasm. In your urethral discharge, painful tender prostate and digital rectal examination, increase in frequency, dysuria, hematuria, fever. Okay, done. Urinary abnormalities leading to acute pyelonephritis. It can be a honeymoon disease. Okay, like that. What's the question? Three urinary abnormalities. Leukocytosis in peripheral smear in urine examination, microscopy, we see pusses, organisms, WBC cast, culture will show uh, more than 10 to the power 5 colony forming units per ml. Calculate obstruction, enlargement. Radionuclide scan for reflux. So urinary abnormalities in acute pyelonephritis is a question. Acute pyelonephritis will have leukocytosis. This is textbook. Colony forming units, organism, pus cells. Other investigation, ultrasonography is done. Computed tomography is done to calculate obstruction. Then we have to find out reflux, and then for parenchymal damage, we do a DMSA scan. Okay, just remember that much. Three types, predisposing factors. Three types of renal stones are predisposing factors. Renal stones, we have oxalate stones, we have calcium stones, uric acid, calcium oxalate stones, uric acid stones, phosphate stones, cysteine stones, and some drug stones. Okay, what are the predisposing factors for this one? High citrus diet, male hormone, male gender, um dehydration, testosterone, diuretics, hyperuricemia, enzyme disorders, renal tubular syndrome, non-metabolic conditions such as infection with protease minerals. So just remember, calcium oxalate crystals, where you can see, we can see in dehydration, we can see in testosterone because it increases endogenous oxalate formation, in diuretics, in case of hypercalcemic states such as parathyroidism, sarcoidosis, milk alkali syndrome, then in uric acid crystals where you get hyperuremic conditions such as tumor lysis syndrome, myeloproliferative conditions, gout. Then in enzyme cysteine stones, homocystinuria, xanthinuria. Then non-metabolic conditions such as phosphate stones where you can see in urea splitting organisms such as this one. Okay. Okay. What is lupus nephritis, honeymoon nephritis? 5 marks, Jesus. Honeymoon nephritis. Cystitis as a result of frequent or prolonged sexual activity, as would typically be expected in honeymoon period of a marriage. Due to prolong, this is not something I would need to stress to remember. So yeah, I think I can finish it in under 20 minutes. Yeah, should be good enough. Honeymoon cystitis caused by prolonged sexual activity, as typically in the marriage, can occur when a woman has, or when has E. coli is the most common one. It's because of the skin around the anus. Uh, Then we have leukoesterase test, positive dipstick test for nitrate, leukoesterase, microscopic cast, and all that. Same thing, bro. Just hot tremoxazole we can give. Honeymoon cystitis you got no. Just write about it's because of what, and then we'll go to because of what it is, and E. coli is most common, and then just go to investigations and management. Okay. Lupus nephritis. Yes. Not it. And lupus antibodies affect structures in the kidney. So, this I think we can definitely read up more in SLE section. Hematuria causes done. What is hematuria? Presence of blood in this one urine. It can be because of, remember the first causes, malignant hypertension, vasculitis, thrombotic microangiopathy, and glomerulonephritis. Other than this, tumor, schistosoma, trauma, obstruction, stone. Okay, and then we have the supernatant sediment, all that stuff. Fine. This is done. Acute renal failure causes pre-renal, renal, post-renal, uh, complications and management. That was complications of this one, dialysis, hypotension, cardiac arrhythmia. See, it's very common sense. Hypotension is the most common. After that, we have cardiac arrhythmia. After arrhythmia, we can have cerebral edema. So there's dialysis-related dementia, dialysis-related dialysis-related disequilibrium syndrome, dialysis dementia. We have hypotension, cardiac arrhythmia, infection, air embolism, pulmonary edema, infection, hemorrhage due to antibiotics, infection, uh, anaphylactic reaction to medications, all that. Okay. Recurrent UTI infection causes and its management. So we have acute renal failure, some things left. Management, complications, and then go with indications for renal transplant. Indication for renal transplant. Come on, bro. Anybody who is on uh, HLA type, cross type, not an immunosuppressive therapy, this shit, that shit, no complications, no contraindications. Now what you can write actually, indications for this one. Any patient who is on renal replacement therapy must be offered renal transplant. Okay. Any patient who's on renal replacement therapy must be offered a renal transplant. I don't know, indicate, I just ruled off contraindications. Contraindications, we have absolute and relative. So in absolute, we have uh, reversible causes of this one, vasculitis. Then we have drug abuse, psychiatric illness, congestive cardiac failure, DIC. Then in relative indications, we have tumor, we have diabetes, we have active infection here. So no, a patient who's on renal replacement therapy who is no, having none of these contraindications can be treated for renal transplant. What are the indications? With the different types of renal transplant therapy. The different types of renal transplant therapy, we have we have hemodialysis, ultrafiltration, we have traditional hemodialysis, peritoneal renal replacement therapy. We have traditional hemodialysis, peritoneal. We have hemodialysis, hemofiltration, hemodiafiltration, peritoneal dialysis. We have six types. Okay, peritoneal dialysis, uh, intermittent hemodialysis, intermittent hemofiltration, continuous hemofiltration, continuous hemodialysis, hemodiafiltration, and renal transplant. Okay, this is important. This is the types of renal transplant therapy.